This recording will go over urolithiasis. Urolithiasis is the presence of calculi or stones in the urinary tract. Urolithiasis is the same as renal calculi, which is the same as kidney stones, just different names for the same thing. Stones often do not cause symptoms until they pass into the lower urinary tract, where they can cause excruciating pain. Stones are particles in the urine that occur in amounts too high to stay dissolved, or they become supersaturated in the urine. As a result of supersaturation, the particles precipitate and collect to form calculi. The most common condition associated with stone formation is dehydration. Most stones contain calcium. Struvite, uric acid, and cysteine are more rare compositions of stones. Formations of stones involve two conditions. The first one is supersaturation of the urine with the particle element, whether it's calcium or uric acid, that first becomes crystallized and later becomes the stone. The second one is formation of a nidus, deposit of crystals that can be the point of infection along the lining of the kidney and urinary tract. In addition to low urine volume, high urine acidity or alkalinity, as well as drugs, contribute to stone formation. One example of a metabolic problem causing stone formation begins when excessive amounts of calcium are absorbed through the intestinal tract, leading to hypercalciuria. As blood circulates through the kidneys, the excess calcium is filtered into the urine, causing supersaturation of calcium in the urine. If fluid intake is poor, such as when a patient is dehydrated, supersaturation is more likely to occur. Any stone may result in obstruction within the urinary tract, which can threaten both glomerular filtration rate, or GFR, and kidney perfusion. When the stone occludes the ureter and blocks the flow of urine, the ureter dilates. Enlargement of the ureter is called hydroureter. The pain associated with ureteral spasm is excruciating and may cause the patient to go into shock from stimulation of nearby nerves. Hematuria, or blood in the urine, may result from damage to the urothelial lining. If the obstruction is not removed, urinary stasis can lead to infection and impair kidney function on the site of the blockage. As the blockage persists, hydronephrosis, or enlargement of the kidney caused by blockage of urine lower in the tract and filling up of the kidney with urine, and permanent kidney damage may develop. The vast majority of adults who form stones have a metabolic risk factor. The cause of stone formation in a susceptible adult is dehydration. Other metabolic problems that can cause kidney stones include hyperparathyroidism that results in hypercalcemia, leading to the development of calcium stones. Also, gout can lead to the development of hyperuricemia, which could lead to the development of uric acid stones. Patients who are white, obese, or have diabetes or gout have increased risk for initial stone formation. The incidence of stone disease is high and varies with geographic location, race, and family history. The incidence of most stone types is higher in men, although struvite stones are twice as more common in women. In terms of assessment, ask the patient about a personal or family history of urologic stones. Obtain a history of their diet, fluid intake patterns, and any supplemental vitamins or minerals they are taking. Ask if they have a history of stone formation and what sort of treatment they have received. The major symptom of stones is severe pain, commonly called renal colic. Flank pain suggests that the stone is in the kidney or upper ureter. Flank pain that extends toward the abdomen or to the scrotum and testes or the vulva suggests that the stones are in the ureters or the bladder. Pain is most intense when the stone is moving or the ureter is obstructed. Renal colic can be described as waves of sharp and intense pain caused by kidney dysfunction. Renal colic begins suddenly and is often described as unbearable. Nausea, vomiting, pallor, and diaphoresis often accompany the pain. However, a large stationary stone in the kidney rarely causes much pain because it's not moving. Frequency and dysuria occur when a stone reaches the bladder. Oliguria, or scant urine output, and anuria, absence of urine output, suggests obstruction and possibly at the bladder neck or urethra. Urinary tract obstruction is an emergency and must be treated immediately to preserve kidney function. Assess the patient for bladder distension. He or she may appear pale, ashen, and diaphoretic, and may have excruciating pain. Vital signs may be elevated with pain. Body temperature and pulse are elevated with infection. Blood pressure may decrease if the severe pain causes shock. Urinalysis is performed in patients with suspected stones. Measurement of urine-specific gravity and osmolarity can provide a clue about the adequacy of fluid intake. Urine pH can help in the determination of stone type. A 24-hour urine analysis can determine whether supersaturation of common stone particles is present. Hematuria during renal colic is common, and blood may make the urine appear smoky or rusty. Red blood cells are usually caused by stone-induced trauma to the lining of the ureter, bladder, or urethra. White blood cells and bacteria may be present as a result of urinary stasis. Increased turbidity or cloudiness and odor indicate that infection may be present. The serum white blood cell count is elevated with infection. Increases in the serum levels of calcium, phosphate, or uric acid levels indicate that excess minerals are present that may contribute to stone formation. The current standard for confirming urinary stones is a CT scan of the abdomen and pelvis. In settings where a CT is not available, a plain abdominal KUB X-ray is useful. Nursing interventions focus on promoting comfort and preventing infection and urinary obstruction. Most patients expel the stone without invasive procedures. Size is the most important factor for whether a stone will pass on its own. Its composition and location are also factors. The larger the stone and the higher up in the urinary tract it is, the less likely it is to pass. When the stone is passed, it should be captured and sent to the lab for analysis. Other interventions are needed when the stone does not pass spontaneously. In the clinical setting, if you have a patient who is in with kidney stones, you want to make sure that they're straining their urine. And if any stones are caught while straining the urine, we want to make sure that those stones are sent to the lab so they can be identified. Non-surgical management of kidney stones include drug therapy and lithotripsy. Drug therapy is needed in the first 24 to 36 hours when pain is most severe. Opioids or NSAIDs may be used. When NSAIDs are used, there is an increased risk for kidney impairment from reduced perfusion. NSAIDs interfere with renal autoregulation, and the risk for impairment is greater among patients with pre-existing kidney dysfunction. Risk for bleeding also is increased from platelet inhibition with NSAIDs when they're used. Control of pain and promotion of comfort are more effective when drugs are given at regularly scheduled intervals or by a constant delivery system instead of PRN. Antispasmodic drugs, such as oxybutynin, are important for control of pain. Other management techniques include avoiding overhydration and underhydration in the acute phase to help make the passage of stone less painful. Strain the urine and teach the patient to strain it to monitor for stone passage and send any stone pass to the lab for analysis, because preventative therapy is based on stone composition. Antibiotics may be used to manage struvite stones because these are associated with urinary infections. When urease-producing bacteria remain in the urine and within the stone, urine becomes alkaline, causing phosphate to precipitate and allow staghorn-shaped struvite stones to form rapidly. Two drugs that may be used to aid in stone expulsion are thiazide diuretics and allopurinol. These drugs, combined with high fluid intake, increases urine volume or decreases urine pH and help to increase the excretion of the stone or stone fragments. Alpha-adrenergic blockers and calcium channel blockers can shorten the time to stone passage by relaxing smooth muscle within the ureters. Citrate may be used to alkalinize urine pH and dissolve uric acid stones. A stone that has not passed within 1 to 2 months is unlikely to pass spontaneously. Other options for stone intervention are considered when infection occurs, when pain cannot be well managed, or when there is an actual or increased risk for reduced kidney function. Lithotripsy, or extracorporeal shockwave lithotripsy, is the use of sound, laser, or dry shock waves to break the stone into small fragments. After lithotripsy, strain the urine to monitor the passage of stone fragments. Bruising may occur on the flank of the affected side. Occasionally, a stent is placed in the ureter before shockwave lithotripsy to ease the passage of stone fragments. Minimally invasive surgical and open surgical procedures are used if urinary obstruction occurs or if the stone is too large to be passed. Minimally invasive surgical procedures include stenting, ureteroscopy, percutaneous ureterolithotomy, and percutaneous nephrolithotomy. Stenting is usually performed with a stent, a small tube that's placed in the ureter by ureteroscopy. The stent dilates the ureter and enlarges the passageway for the stone or stone fragments. Ureteroscopy is an endoscopic procedure where a ureteroscope is passed through the urethra and bladder into the ureter. Once the stone is seen, it is removed with grasping baskets, forceps, or loops. Lithotripsy can also be performed through the ureteroscope. A Foley catheter may be placed to facilitate passage of stone fragments through the urethra. Percutaneous ureterolithotomy or nephrolithotomy is the removal of a stone in the ureter or kidney through the skin. Often, a nephrostomy tube is left in place at first to prevent the stone fragments from passing through the urinary tract. Monitor the patient for complications after the procedure, including bleeding at the site or through the tube, pneumothorax, and infection. Monitor nephrostomy tube drainage for volume and the presence of blood in the urine, which is normal for the first 24 to 48 hours after tube placement. Provide routine nephrostomy tube care with sterile dressing changes and tube flushing if ordered. When other stone removal attempts have failed, or when risk for a lasting injury to the ureter or kidney is possible, an open procedure may be performed. In terms of post-op care, follow routine procedures for assessment of the patient who has received anesthesia. Monitor the amount of bleeding from incisions and in the urine. Maintain adequate fluid intake. Strain the urine to monitor passage of stone fragments. Teach the patient how to prevent future stones with dietary changes, including consistent daily fluid intake to avoid dehydration and supersaturation. Infection control before invasive procedures is critical for preventing urosepsis. Interventions include giving antibiotics, either to eliminate an existing infection or to prevent new infections, and maintaining nutrition and fluid intake. Because infection always occurs with struvite stone formation, the healthcare team plans for long-term infection prevention. Nutritional therapy ideally includes adequate calorie intake with a balance of all food groups. Encourage a fluid intake sufficient to dilute urine to a light color throughout the 24-hour day, typically 2 to 3 liters per day, unless another health problem requires fluid restriction. In terms of preventing obstruction, measures to prevent urinary obstruction by stones include high intake of fluids, 3 liters or more a day, and accurate measures of intake and output. Fluid intake sufficient to provide diluted urine helps prevent dehydration, promotes urine flow, and decreases the chance of crystals forming a stone. Drug therapy to prevent obstruction depends on what is causing stone formation and the type of stone formed. Teach the patient the reasons for the drug and assess for side effects and adverse reactions. Drugs to treat hypercalciuria or high levels of calcium in the urine include thiazide diuretics. For patients with hyperuricemia or chronic gout, allopurinol may be used to prevent the formation of uric acid stones. Nutritional therapy depends on the type of stone that is being formed. Please review Table 66.5 on your own. Other measures can help the stone pass more quickly. Urge the patient to walk as often as possible. Walking promotes passage of stones and reduces bone calcium resorption. Check the urine pH daily and strain all urine with filter paper or a special urine sieve or strainer to collect past stone fragments. Please review Chart 66-11 on your own.